Well, good evening and welcome to another edition of Question Lab. I'm your host, Jeff Downing, and again, tonight we're going to be covering GI system. We've got a nice set of questions that Abraham has put together. I think you already introduced yourself.
Yes, I did. So yeah, I'm a hematology oncology fellow at the University of South Alabama. I've been working with Scholar-Rx and helping many students such as yourselves through step 1, step 2, and even step 3. Excited to be here, go over some high yield GI, and try to learn something from today. That's the one I want you guys to take away. Just even one little nugget of information I want you to take away from today.
That's right. So, for some of you, this may be your 10th, 20th, 50th Q Lab. I know I see some familiar faces in the crowd, and but what I want to do first is learn a little bit about you. So what I'm going to do is I'm going to launch the first poll of the night, and this is going to be the easiest question. Who are you? I want to see who is in the crowd tonight. It's a January, relatively new year. Some of you may be thinking about step 1. Some of you may be thinking about step 1 and step 2. So go ahead and let us know. Are you, where you are on your journey, M1, M2, M3, M4, or an IMG or an FMG? All are welcome. All are appreciated. We've been doing this. We're getting close, ladies and gentlemen, to the 6-year anniversary of our first question lab. So I think this is probably our 188th episode. So in any case, we're happy you're all here. So what I'm going to do is, typically when we do these polls during the session, I wait until about 3/4 of you voted. So it looks like we've reached that threshold. So what I'm going to do is I'm going to end the poll and share the results. So it looks like we've got a good contingent of IMGs and FMGs in the house, and a number of M2s and M3s and even an M4. So we are happy that you are all here. And again, we want to do our best to make the most of our time together. So what I'm going to do is I'm going to close the poll and just kind of set the table. So here, what we do in Question Lab, we're going to walk through a set of questions tonight connected to GI. At the end of the event, we're going to have a raffle, and one lucky attendee is going to get a free subscription to RX 360 Plus. I'll also have a special discount for those of you who are here. But again, for us, the team here from Scholar-Rx, we're always looking for ways to help students and IMGs like yourselves be ready for test day, be ready for your exams. And in order to do that, we want to make sure that we're covering the content properly, but we also want to help you with your methodology, right? We want to ensure that, especially, for those of you that are, kind of early on in your prep, that, you're starting to think more about, well, hey, I'm my knowledge base is starting to solidify. I'm starting to really get a sense of, what I need to know. But we also really want you to be prepared for test day. So, as we walk through these questions, we're going to be, modeling what we think is, a good test taking technique, especially for step 1. So that's what we're going to do. And if you have any questions, that's what the question box is for. So please let us know if you've got questions, comments, anything that would be useful. Okay. So with that, we are going to start with question number 1. And the first thing you're going to notice is that there's something missing on this slide. And that is by design. We ask you to begin by covering up the answer choices. Okay. Again, for us, we want you to be able to efficiently slice and dice questions on question day, and we really want you to be focused. So we ask you to cover up the answer choices. Answer choices aren't going to do you any good yet, right? So by covering them up, you're helping to kind of filter out what is extraneous information right now. And you can also, sometimes get distracted by, perhaps there is a disorder or a mechanism, something that comes up in the answer choices that you've struggled with or that you don't know. And again, little things like that can throw you off your game. So we say cover up the answer choices. And then step 2, we ask you to read the lead in. And in this case, the lead in is the actual question. So for this question, the lead in says or asks, which of the following is most likely related to this patient's diagnosis? Okay, so now if you go in and you read the stem first, if you read that vignette, you're getting data, but you don't really necessarily know what it is you're trying to determine. You start with a lead in, now you have your compass, right? Now you understand what it is that you're going to be, pushing towards as you read the vignette. So now that we know a little bit about what it is we're trying to get, we can read the vignette. An 18-month-old boy is brought to his pediatrician because of intermittent bloody stools in his diapers for the past 2 weeks. There's no history of pain, fever, or diarrhea. On physical examination, he is playful and interacts appropriately. His abdomen is soft and non-tender without organomegaly. The results of anorectal examination and complete blood count are unremarkable. Guaiac test result is positive. So again, which of the following is most likely related to this patient's diagnosis? Think about the steps that it will take you to get to the answer while I turn it over to Abraham.
All right. Yeah. Jeff had some really high yield points there. He was talking about reading the lead in, making sure you kind of understand what the question's asking about before taking on the vignette. This isn't the biggest vignette, but you're going to have some questions with really fat, beefy vignettes where it feels overwhelming with the amount of information they're giving you. So reading that lead in really helps you get into it. But in this question, let's highlight some keywords here, and let's try to figure out what am I looking for in the situation. Again, which of the following is most likely related to the patient's diagnosis? So, you want to think, okay, well, what's the patient's diagnosis? And then what is a related, feature of it? Whatever of the options matches that the best. I'll go back to the vignette now. So it's an 18-month-old boy. We talked about, okay, he's a pediatrician. He has intermittent bloody stools. That's his only complaint. So it's the complaint the parents notice. 2 weeks. Okay, so 2 weeks of bloody stools, but everything else is fine, right? No fever, no diarrhea, no pain. He's feeling okay. Physical exam is otherwise normal. But there is the Guaiac testing, which is positive. What does that mean to you? It should mean something right away to you. So that tells you, okay, there's something going on and fits the picture. Look at what's common in this situation. Think about what the diagnosis could be in an asymptomatic, otherwise young male patient that presents like this. So let's take a second, try to think about that. You can drop it in the question box if you'd like, but let's pop the options open right now and let's talk about what could they possibly be. This is very typical of STEP. Usually 5 options is what they're going to typically give you, sometimes more, sometimes less. You want to just be familiar about reading them. I like to start with E and make my way up to make sure I go through every option and don't just go with the first one that possibly could be related. Option E is tear in the anal wall. Option D is persistent vitelline duct. Option C is one portion of the intestine sliding into another. Option choice B, inflammation of the colonic mucosa. Option choice A, bacterial infection of the intestinal cells. Now, all of these relate to a different condition, right? They could be different syndromes, different conditions that we need to know, but only one of them really fits this diagnosis the best. What could this be? Take a second, look at the big picture, and then as we give you a few seconds before we pull the poll up and pick what you think could be the best answer in this situation.
Okay, everybody, what I'm going to do is I'm going to launch the poll, give you a chance to tell us which of the following is most likely related to this 18-month-old boy's diagnosis. Looks like the poll's a little bit slow, but I'll give you guys plenty of time. One thing we always remind you is that on step day, you never want to leave a question unanswered. So you're in question lab. I'd love to see 100%, in terms of the number of votes cast, but looks like you guys are doing a pretty nice job here in terms of getting your vote submitted. So I'm going to go ahead and end the poll and share the results. Okay, so interesting breakdown. Almost half of you went with persistent vitelline duct. Well, at just a little under a quarter of you were thinking that maybe it's one portion of intestine sliding into another, but also got some votes for bacterial infection of intestinal cells, inflammation of colonic mucosa, and even tear in the anal wall. So interesting. Let's go ahead and close the poll. And we will reveal the answer. And the answer is answer choice D, persistent vitelline duct. So nice work. Almost half of you got that one right, which is a good start. But it's not about the results. It's really about the understanding. So Abraham is going to be here to walk us through this one. Go ahead, Abraham.
All right. Great job, guys. I think, again, this can be tricky. This is one where they're not giving you too much information to work with, and you kind of want to think, okay, what's common, what's going on with this patient, and kind of really rule out other options. Now, I see a lot of people were like, hey, could this be something called intussusception, right? That's option D. Option D is intussusception, one portion of the intestine sliding into another. The telescoping, that's the kind of what's happening where they kind of slide into each other. Well, intussusception is a very good differential, and that's probably the second best answer in this situation. But these people typically have pain or current jelly stools associated with it, which is a little bit different then, right? They have more mucus-like stools. Here they're just saying simply bloody stools, and the patient has no pain at all. So if I think current jelly stools and some pain, that's going to be my intussusception. That's when you would start thinking about a C as the option. Now, what do I mean by persistent vitelline duct? Well, persistent vitelline duct is referring to Meckel's diverticulum, a very high yield topic that you need to know, especially in your pediatric GI questions. They love to ask about it. So there's different ways they can phrase it. So a persistent vitelline duct is explaining, okay, where did it derive from, right? The Meckel's diverticulum is a true diverticulum that derived from that vitelline duct that should have dissipated as the baby is aging, right? So this is when it's persistent, it's staying there. And another way they can sometimes describe it is that as ectopic gastric tissue that's present in this area. And that's what really triggers that bleeding situation. Okay, so you want to see a young, and then there's something called the rule of twos. That's also something that they'll often refer to as well, where typically it's 2 inches long, 2 feet from the ileocecal valve, and then contains either pancreatic or gastric tissue, which is that 2 tissue. And typically occurs around 2 years of age, before 2. So again, in this situation, this is like 18-month-old boy, so less than 2. That's typical. And then him having that the guaiac stool test positive is essentially telling you there's blood in the stool confirmed, right? It's not just a clinical saying, hey, there's intermittent bloody stools. There's confirmed bloody stools on the testing. But he's otherwise asymptomatic. These people, you should think about it being Meckel's diverticulum. And that GWAC test positive just means blood is detected in the stool. That's all that means. That's just a big fancy word that they use to throw people off. But you just need to, when you see that, they mean that there's blood found in the stools. Other options here, a lot of you guys picked inflammation of the colon as well. We'll talk. So that's typically not going to present like this. Typically when you have inflammation of the colon, think ulcerative colitis, they have abdominal pain, weight loss, and this patient is generally too young to develop something like that. Think a little bit older. Think about teenagers, young adults. Those are the typical presentations you're going to see with ulcerative colitis. Bacterial infection, again, not typically in the situation. There's no fever, no lethargy, nothing like generally ill about the patient, so you shouldn't be really thinking there's an infection going on. This is probably just a persistent vitelline duct that's present. It's bleeding. It's Meckel's diverticulum, a true diverticulum. That's the buzzword that they'll use when they're describing this. And then finally, tear in the anal wall. There's a normal physical exam, so it shouldn't be a tear there. You would see it externally if they did see an anal fissure, for example. But great job, guys. I think that those are some very classic findings that you're going to look for, and then you want to try to connect all these together to get the right answer. Good job.
Okay, nice work, everybody. We are off and running. I know a few of you have just recently joined. So again, we are in our gastrointestinal question lab tonight. So all of these questions are going to relate to GI for step 1. And we are ready for question number 2. So again, we have those answer choices covered up, and we're going to begin by reading the lead-in. Which of the following is the most likely etiology of this patient's disease? Okay, so now we already know what we're going to be thinking about as we start parsing through the vignette. So let's do that now. A 55-year-old man presents to the clinic with a 3-month history of epigastric pain and nausea. He further complains of fatigue and a tingling sensation in his toes and lips. He denies diarrhea and constipation. He has a history of autoimmune thyroiditis. Upper endoscopy reveals a chronic inflammatory process affecting the fundus and body of the stomach. So again, which of the following is the most likely etiology of this patient's disease? Think through that as I pass it over to Abraham.
All right. Yeah, I was just answering a couple of these questions. I think you guys had some great questions on the last one, and hopefully I'll get a chance to answer the rest of them as well. But let's go through this question here, and let's kind of take it step by step and try to get an understanding of what's going on here. Right, so this question, again, we have an adult this time, and it's a little bit of a different presentation. We're dealing with GI. They're going to deal with some of the classic presentations, but the question, the lead in here is asking most likely etiology, right? So what's the cause? Very clearly asking you. It's not asking what's related, what's the treatment, what's the cause. Let's go through, let's highlight some keywords here, and let's try to get a good understanding of what's going on, what the diagnosis is, and then take it from there, okay? So most likely etiology, like we already know that. You got a 55-year-old man, again, 3-month history of epigastric pain, right? You got to think about epigastric, what's there, what could they refer to? There's abdominal pain is very vague presentation, so you always want to localize it. Is it right upper quadrant, left upper quadrant, epigastric? Is it suprapubic? Those are all different areas in the belly, and you got to understand what is present in that area to help us visualize. He has fatigue, tingling sensation of his toes and lips, and then otherwise feels okay. No diarrhea, no constipation. He has a history of autoimmune thyroiditis, okay. And then he had an upper endoscopy, an EGD. Shows chronic inflammatory process, and that's involving the stomach. Okay, so chronic inflammation of the stomach. He's got a history of autoimmune disease. He has his fatigue, this tingling toes, and you want to just see the full picture and try to find a unifying diagnosis. Majority of these step questions, there's one thing that can explain everything that's going on, right? It's very rare for them to have 2 separate things happening at the same time. You want to think about it like a test writer, and there's giving you these clues for a reason. There are going to be distractors sometimes, but majority of the information they give you, especially in a vignette that's not that big, you want to take it and be like, okay, what are they trying to get at with this? What are they trying to get at with this? And really get into that test writer's mind. So take your time, think about what this diagnosis could be, and then think, okay, what's the cause of this diagnosis? So let's go through it. Let's drop the options here and let's take a second and really digest what's going on here. Again, I like to start with E and I'll work my way up. And if you guys know the answer, you guys can type it out in the question box or wait till the poll pops up. Option choice E, self-reactive CD4 T cells. Option choice D, infection with Tropharema whipplei or T. whippleii. C, infection with Helicobacter pylori. Option choice B, gastrin secreting tumors. Option choice A, antibodies to gliadin. Now, these are all referring to different conditions. I'm going to talk about what each of these are, but I want you to think about it. What makes the most sense in this clinical situation, and what would explain everything that's going on with this guy? Take a second, read over if you need to, as we pull up the poll.
Okay, everybody. You've gotten a nice breakdown of the vignette. You can see some of that key data that's sitting there for you. So hopefully you've got a sense of the diagnosis and what's likely causing it. Okay, so with that, let us launch the poll. And here you go. You can let us know what you're thinking. Cause this 55-year-old man's disease. Looks like everybody is jumping in here. This is good. Appreciate all of the questions and comments that you guys are putting into the question box. This is why we're here. It's also helpful for us to get a sense of your thinking, right? You know, what either what's tipping you off or what might be misleading you, right? That's, you know, that is really one of the key elements that the NBME item writers are trying to do. They're trying to, you know, plant little informational seeds that, you know, are going to test whether you really know this or not. Okay. Well, gosh, almost 90% of you have voted. So let's go ahead and end it and share the results. So again, we've got quite a few of you behind one of the choices. In this case, self-reactive CD4 T cells. 44% of you went with that option, and almost a quarter of you went with infection with H. pylori. And then there's kind of some of you were thinking antibodies to gliadin, gastrin secreting tumors, and a few thinking T. whippleii. Okay, interesting breakdown. So let's go ahead and close the poll and reveal the answer. And the answer is answer choice E, self-reactive CD4 plus T cells. So good job, everybody. I guess we're off to a really nice start tonight. This is, you know, these are, you know, always challenging. You know, sometimes the questions that don't have a huge vignette can be challenging because you really have to know, you know, well, what is it that is illuminating the particular diagnosis. So well done. But regardless, even if you didn't get it right, or if you got lucky, that's fine. This is the night to be candid about that, right? Because Abraham is going to lead the way through this one. So Abraham, why don't you take it away?
All right, great job, guys. Again, this one's not as easy as the last one, but you guys still were able to get the correct answer. They purposely didn't make it an obvious option, and they did throw in some distractions in here. So I want to make sure you guys see the full picture. Okay, so let's start off by diagnosing this guy. So you have this 55-year-old guy. He has a history of autoimmune disease, right? So if you have one autoimmune disease, you can have other autoimmune diseases, right? They come in bunches. That's the way you would think about it. And he's having this 3-month history of epigastric pain, right? What's in the epigastric region? Mainly the bottom of the esophagus leading into the stomach. So it's probably the stomach that's causing all this problem. and then fatigue is going on. So fatigue can be many, many things, but could be an anemia picture going on. And then tingling, numbness, so some kind of neuropathy, right? So some kind of tingling sensation. So whatever the cause of neuropathy is. So anemia, maybe neuropathy, and then the classic gastric pain, and then the fact that he has an autoimmune history, and then they do a scope and they do a biopsy, and this gives it away. There's chronic inflammatory process. What that means is that there's typically means that there is some type of lymphocytes present, something hyper chronic inflammation going on there. So, and that's in the stomach itself. So you have to connect these dots and be like, hey, what makes sense to explain everything together? And the diagnosis in this situation is pernicious anemia. Now, if you guys don't know what pernicious anemia is, it's a very high yield topic for step 1 and step 2 that they want you to understand what this is. So pernicious anemia is essentially an autoimmune destruction of certain cells in the stomach, okay? And this leads to autoimmune gastritis. Now, these are cell-mediated immunity. So if you do immunology, you'll learn the difference between humoral immunity and cell-mediated immunity. This is cell-mediated immunity where you have your T helper cells directly target parietal cells, and they'll damage and destroy parietal cells. Parietal cells are the cells inside the stomach that are helping secrete intrinsic factor to help our body absorb B12. So it's kind of like a pathway, right? So it starts with these autoreactive or self-reactive CD4 T cells, which damage the parietal cells in the stomach, which then makes it so that your body doesn't secrete intrinsic factor, therefore your body doesn't absorb B12, so you become B12 deficient. Now, what do I know about B12 deficiency? Megaloblastic anemia, which explains the fatigue, and neurological symptoms, right? They get that subacute combined degeneration, which you learn in neurology. But they get that, just generally think about tingling sensations in the toes and lips. That's what they're hinting at. They're hinting that he's got something neurological going on. The fatigue is pointing towards that anemia. And then that autoimmune history is really getting you to think about, okay, could this be a pernicious anemia situation? And then the biopsy or the endoscopy showing chronic inflammation is kind of the nail in the coffin, which confirms everything that you suspected. Let's look at the other options and let's try to see why couldn't it be, H. pylori, right? A lot of you guys picked H. pylori, which is a good option. And it would have a gastritis, right? H. pylori is a classic ulcers in the stomach pain, but they wouldn't have the neurological features. And, even the, endoscopy, they may have shown like, oh, there is like, curved bacteria noted under the microscope or something like that to point more towards H. pylori. But you're not going to have that, tingling and the neurological features you would expect. You can still be anemic because, H. pylori can still cause ulcers which bleed in the stomach, but not necessarily going to have that neurological features. The other options, antibodies to gliadin, that's really pointing towards celiac disease. So that's going to be that classic story of, malabsorption, weight loss, people, especially with gluten intolerance, then, people, when they eat bread and stuff, they notice these kind of side effects. That's going to be the gastrin secreting tumor, that's Zollinger-Ellison syndrome. That's going to be the classic, ulcers noted on EGD. There's a gastrin secreting tumor, generally in the pancreatic area, leading to peptic ulcers that are recurrent despite initial treatments. Again, no neurological features for either A or B. And then option choice D is an infection, T. Whippleyi or Whipple's disease. Again, they'll have joint pain or weight loss, diarrhea. Again, not very common to have this presentation in that situation. But great job, guys. I think this is a good question to really test you on, when I think stomach pain, what could be going on, and then using the rest of the story to really understand the picture. This is pernicious anemia, very high yield, but great job.
Okay, nice work, everybody. You guys you're really locked in. Time for a quick stretch break. I know that a lot of folks out here do use USMLE-Rx. I want to just launch a quick poll. It's helpful for me to know what our audience is using or not using. So let's just do a quick poll here. Our team has been helping students prepare for step 1 since 2005. That was when we launched the first version of QMax. And, we've obviously, focused on, what are the things that we can do to help students succeed, and more recently, really helping, schools who are, trying to find ways to better serve the future physicians as they get ready for boards and, How do you make sense of all of the, the content that you're trying to absorb? We've got some M1s, M2s here, M3s, I remember a orientation at UC San Diego a few years ago where they said, you're gonna need to learn about 40,000 facts over the course of med school, and then kind of broke down to you needing to learn something every 20 minutes. So for us, we've always been really focused on, well, what is it that we can do to make this journey a little more fruitful and a little more painless. So let's see. We've got some 360 plus users and FlashFacts users. We've got some folks that are interested. So that's great. Either way, we do have a special offer that we're going to share at the end of tonight's session. But again, our system is integrated. We really want to help you learn all that core content through our bricks, and then to be able to review and reinforce it with our videos and FlashFacts and our study stream system. And then obviously QMax is, our tool for helping you assess yourself as you prepare for step 1 and step 2. We've got 2 self-assessment exams. They're half-day self-assessment exams for step 1, and we just released a step 2 self-assessment exam a couple of months ago. So that's our first step 2 half day. So anyway, we've got a lot that we offer, and we've got a number of new things on tap this year. So definitely encourage you to check it out. And for those of you doing your trial, we'd love to hear your thoughts. So with that, hopefully everybody has caught their breath, ready for the second half of tonight's event. So let's get into question number 3. This is where, probably upping the challenge level a little bit. So, and I'm sorry, I didn't really want to structure the slide this way. I rarely go 2-column, but because of the lab tests, I went ahead and did that. So starting with the lead-in, is there on the right side in the top of the right column. So let's go there. Which of the following is the mechanism of action of the most appropriate acute first-line treatment for this patient's condition? That's a mouthful, right? You can see multiple steps, embedded within that lead-in. So, but it does give you a sense of, well, what is it that we're going to be trying to determine? So let's go to the vignette. A 37-year-old man is brought to the emergency department because of increasing lethargy and confusion. The patient slurs his speech and is unable to give consistent answers. He was recently diagnosed with hepatitis C. Vital signs are within normal limits. Physical examination reveals yellowing of the sclerae. His abdomen is distended. When he is asked to extend his arms and dorsiflex his wrists, there is a flapping tremor. Lab tests show the following. So you can see all of the lab numbers. I'll let you look at those yourself. So once again, the question, which of the following is the mechanism of action of the most appropriate acute first-line treatment for this patient's condition? Think about how you're going to attack this one as I pass it over to Abraham.
All right. So, like I said, as we get through the questions, they're going to get a little more difficult. This is a good high yield question as well, kind of a bigger vignette, for example. So this is when reading the lead-in really matters, really understanding what's going on. And this is, like Jeff said, a multi-step question, not just what's the diagnosis. It's asking about what's the mechanism of action of the most appropriate first-line treatment. So I want you to know diagnosis, first-line treatment, how does it work? Okay, so let's go through, let's highlight some keywords here, and let's hopefully figure out what's going on in this patient. Okay, so we have Again, a 37-year-old man. Okay, you need to know kind of I like to know demographic. Who am I dealing with? Increased lethargy and confusion. Okay, he slurs his speech and is not giving consistent answers. He has a history of Hep C. Okay, that's important. Vitals are okay otherwise. He's yellowing in the sclera. What do you call that? And then his abdomen is distended. Why is his abdomen distended? And then when he extends his arms and dorsiflex his wrists, there is a flapping tremor. There's a name for this as well. And then I look at the following labs. So albumin, low. I highlighted left and right to make it easier for you guys. You guys don't have to pull up the labs. Left means low, right means high. So his albumin is 2, which is low. Billy total is 3.3, which is high. Alk phos is 100, which is high. AST and ALT are both mildly high at 46.75. And then prothrombin time, PT, is also high. All right. So these are some classic presentation of this patient, right? You want to kind of understand what's happening with this patient and then use that to then think, okay, what am I going to give to this guy? Okay. Again, first line treatment for his current condition, and then think about how does that work? Much more difficult question than the last two, but definitely a very step one style question. Expect you to understand the mechanisms of drugs, mechanisms of how things work, really understand the nitty gritties of it. All right, let's take a second. If you want to read through it one more time, you can. Let's pop all the options up here and let's give you guys a chance to get the correct answer. All right, and I see a lot of people putting the right terminologies for this hand tremor and abdominal distension. So great job, guys. Which of the following mechanisms most appropriate for acute first-line treatment for this patient? Okay, so option E, removal, filtration, and reinfusion of serum. Option choice D, killing of colonic flora. Option choice C, decreased amino-containing substrate. B, alkalinization of the colonic contents. Or A, acidification of the colonic contents. Now, all these are valid and they are referring to different things that are happening and different treatments you can possibly give. But the question is particularly asking for the first line treatment acutely in this guy, what do I want to do? So if you guys want to drop the drug name in the question box, that'd be great. If you guys already think about which of the following mechanisms of action fits the drug the best, that's also great. So take your time as we give you a second to read over one more time before we pull up.
Okay, take a good look at this. We've got this is one of those questions that is so long that kind of it stresses the GoToWebinar character limit. So I go ahead and launch it. Give you a chance to tell us which of these mechanisms of action is the most appropriate acute first-line treatment for this 37-year-old man's condition. This is, again, a good example of why having a methodology going into test day is helpful, because you may understand, you may be able to answer many, or some cases maybe all of the questions in a block, but you don't have a whole lot of time, and you're really going to have to be methodical when it comes to how do you get to that right answer, or how do you kind of narrow in on the two best choices. So you guys are doing a great job in terms of answering tonight. This is probably one of the quickest question lab audiences that we've had here in a while. So I'm going to go ahead and close the poll and let's share the results. Let's see what we've got here. Okay, so answers A and B were sort of neck and neck. So some were thinking acidification of colonic contents. Others were thinking alkalization. So that was neck and neck. And then again, a little under a quarter of you went with decreasing amino-containing substrates. And some of you were thinking removal, filtration, reinfusion of serum. Nobody went with killing of colonic flora. So that distractor apparently did not distract. But let's see. Let's go ahead and close the poll, reveal the answer. And the answer choice is answer choice A, acidification of colonic contents. Not as big of a spread as some of the other questions tonight. This is definitely a lot trickier, but it was the leading vote getter. So nice work, everybody. But there was a lot to work through here. So I'm going to give Abraham all the time he needs to step us through this one.
All right. Again, very classic question. Great job, guys. If you got it, if you didn't, you guys are right there. I'm sure, you probably thought of the drug and you knew what it was, but you just weren't sure about the mechanism of action. If you didn't know the drug or the mechanism of action or anything that's going on, that's totally fine as well. This is the time to learn. This is the time to understand what's happening in this patient. Right. So let's take a step back. Let's read through the question again, but this time I'm going to use the terminologies that I want you to know. So we got a 37-year-old guy with lethargy and confusion. Okay, so we don't know what's going on. He's confused. He's lethargic. Slurs of speech, can't give inconsistent answers, right? They can call it confabulation, if you say it. That's the word that they sometimes use when they say inconsistent answers. Diagnosed with hepatitis C, right? Hepatitis C is a viral infection which causes liver damage and then can cause cirrhosis, right? Cirrhosis is that scarring, end-stage liver disease. That's the way you want to think about it. Has yellowing of the sclera, right? We call that scleral icterus. Or in general, if the skin is yellow, we call it jaundice. So jaundice and icterus are synonymous. They're the same words. They both mean yellowing of the skin, and then scleral icterus is just yellowing of the eyes. Abdomen is distended. I see some people put ascites in the chat, which is correct. So it is, ascites is what they're describing here, distended abdomen. There's a bunch of fluid in the abdominal space. And why is that? Well, because he has low albumin, right? Albumin is what gives us the caudate pressure that lets us keep our fluid inside the blood vessels and not leaking. In addition to that, he probably has some kind of, portal hypertension, which also leads to fluid leaking out. So it's a combination. And then we extend his arm and dorsiflexes his wrist. He has flapping tremor. There's a buzzword for that called asterixis. You need to be familiar with that as well. So ascites for fluid in the belly, asterixis for this flapping tremor that is going on here. So all of this is telling you his liver is not working properly, right? So that's the whole idea. So he's liver cirrhotic. He's confused. Well, why is he confused? We call that hepatic encephalopathy. When the liver is not working properly, our body is not able to properly get rid of toxins. One of the key toxins our liver is responsible to get rid of is ammonia, right? The liver helps get that ammonia to be in a state where we can just excrete it from our body through our stool. And when the liver is not working properly, well, this ammonia can build up, get into the brain, cause that neurological dysfunction, lethargy, confusion, and just CNS toxicity. And that's what's going on in this patient, right? And then the labs are just kind of confirming that, right? High bili indicates that the liver is also not doing the secondary job of conjugating bilirubin and getting it out of the body. That's what's causing the yellowish discoloration of the skin. The liver is the protein factory of the body. So albumin is going to be low because you're not making proteins. Alkaline phosphatase it can either go up with bone issues or with biliary tract / liver issues. So that's kind of a clue that they're pointing at there. AST, ALT are both elevated. They're not super high because this is chronic hepatitis problem. He's had this for a while. If it's in hundreds and thousands, you got to think acute hepatitis. And then prothrombin time being elevated, we know that, again, like going back to the liver is a very important organ in our body. It's a vital organ. The liver also helps make coagulation, clotting factors in our body. So if our body's not making clotting factors, then our ability to clot goes down. So prothrombin time or INR will rise in liver disease, and it's actually prognostic, right? High PT or high INR is prognostic of a failing liver, just like how low albumin is, less like high bilirubin is. All these things kind of just point towards the liver is not working. So what drug are we going to choose in this guy? This guy has hepatic encephalopathy. What I want to do is I want to get that ammonia out of the body. I want to clear up the brain, right? That's the main problem. That's what's going to hurt him first. I'm not going to fix the liver with a transplant right now. I think I need to first take that toxin, take that ammonia and get it out of his body. The best way to do it in the first line setting is lactulose. Lactulose is the drug, and I see a lot of you guys put it in the chat as well. So good job. Lactulose is my acute first line treatment for hepatic encephalopathy. How does it work? Well, you guys picked it, right? Acidification of the colonic contents. Therefore, reducing the amount of ammonia that's absorbed in the bowel, right? So it goes in there, it acidifies it, causes even diarrhea, and excretes that ammonia from the stool. We want these people to have lots of bowel movements to excrete this toxin from their body so that you're not absorbing that ammonia, which is getting into the CNS. So that's the big picture. That's how you see what's going on. Alkalinization is the opposite of what you want. Alkalinization would actually probably worsen the ammonia absorption. Ammonia is not absorbed in acidic environments, and that's what you have to kind of understand from this picture. Decreasing amino-containing substrates. I know a lot of you guys picked that one as well. Again, that's like saying, hey, eat less protein. Well, this guy already has low albumin. That's probably not the best answer. You don't want them to cut down on the amino-containing substrates because they're going to further lower their protein levels and not really affect that ammonia. Killing of colonic flora. I know 0% of you guys picked that, but there is a drug called rifaximin which works like this, and that's actually an adjunct treatment or a second line treatment for hepatic encephalopathy. So I actually expected some of you guys to pick D, because D, there's a drug called rifaximin, which can actually be a second line treatment. So that's something you want to also think about. And then finally, E, removal, filtration, reinfusion, that's dialysis. And think dialysis for kidneys, not liver, right? Dialysis is going to be to get rid of other like drug overdoses, poisoning, liver failure, kidney failure, things like that. That's what you want to think about. That's explaining dialysis. We don't really do that in hepatic failure. But great job, guys. Hepatic encephalopathy, lactulose, acidification, seeing the big picture, seeing the buzzwords there. And like when they describe these things, you have to kind of have these trigger words in your mind that go off. But great job, guys.
Okay, everybody. There was a lot there, a lot to cover, but all really, I think not only high yield, but helpful ways to think through this. So nice work. We are at the conclusion of tonight's event. So we're at question 4. This is the cleanup spot. As I mentioned, we will have a raffle here at the end, as well as a special offer. So make sure you stick around. And with that, let us open up question number 4. Not necessarily or not nearly as long as question number 3. We'll see about the challenge level. So again, we've got the answer choices covered up, and we'll read the lead in. Which of the following is the most appropriate next step in evaluating the cause of this patient's weight loss? Okay, so once again, we already know that this patient's had some perhaps unexplained weight loss. What's going on? What will, once we've figured out what's going on, what would you do next? So again, another great reason for reading that lead in before you read the vignette. So let's read the vignette now. A 40-year-old man comes to the office because of daily diarrhea over the past 5 months. During this time, his stools have smelled worse than they used to and appear oily. He has lost 9 kilograms over the past 5 months, despite having a good appetite. He is in recovery from alcohol use disorder and has had multiple bouts of acute pancreatitis in the past. So again, which of the following is the most appropriate next step in evaluating the cause of this patient's weight loss? I think where you would go with this question as I pass it off to Abraham.
All right, so we have definitely a shorter question, but they're asking something that's a little bit more maybe in detail as well here. So let's kind of read through again. Reading the lead in is very important here. Next step in evaluating the cause of the patient's weight loss, right? So this is kind of a classic thinking about what's going on, why is he losing weight, and then think about, okay, how do I evaluate, right? This is seen in step 1 and step 2, actually. Step 2, a lot of the questions will be, what's the next step in diagnosis, or what's the next step you want to do to treat this person? So you want to kind of build those habits early and kind of think about, okay, what am I going to do in these situations, and put yourself as the physician or the clinician in the situation. Okay, so let's go through, let's highlight some keywords here, and let's kind of go step by step of what's happening. Again, 40-year-old man, knowing demographics important, middle-aged man, what's going on? daily diarrhea. Okay, so he's having diarrhea every day for the past 5 months. So this is what, kind of maybe call it chronic diarrhea. What's going on? And smells worse than they have, sure, and appears oily. Okay, why is that oily? Lost 20 pounds, 9 kgs in the past 5 months, and he's eating well other than that. And he is in recovery from alcohol use disorder. Okay, that's important to know. And has had multiple bouts of acute pancreatitis in the past. So that should build a picture for you of what's going on, his past, his present, the past 5 months, his weight loss, to really see, okay, why is he having this? Which of the following is the most appropriate next step in evaluating the cause of the patient's weight loss? So if you guys think of it, the patient's diagnosis, you can drop it in the chat, because the question is not asking about diagnosis, the question is about the next step, evaluating the cause of the weight loss. So let's take a second. Let's pull up the options here. Let's try to figure out what's going on and how are we going to better evaluate what's causing the weight loss. Option choice E, Sudan 3 staining. Option choice D, stool ova and parasite test. Option choice C, serum lipase concentration. Option choice B, colonoscopy. Option choice A, anti-tissue transglutaminase IgA assay, or TTG assay. Now, there's some high yield points here, important things to see here, but don't lose track of the initial story. What's happening? It's coming in. Weight loss. Why is he having weight loss? What are you going to do to figure out what's the cause of the weight loss? And look at the clinical story. There's a reason why they gave you all the information they did. But take a second, read through one more time if you want to, as we pull up the poll.
Okay, everybody, let's go ahead and see if we can close strong. You can let us know you think it's the most appropriate next step for evaluating this 40-year-old man's recent weight loss. You can also feel free to drop us a comment in the question box. Let us know if there are topics that you would like us to tackle in future editions of Question Lab. I know that many of you would like to see more Question Labs. Right now we are still in more of a monthly cadence, but we recognize the desire. We know how much many of you enjoy these sessions, so we'll do our best. Okay, let's see. Folks, taking a little bit more time with this one, and for good reason. But about 80% of you have voted, so I'm going to go ahead and get ready to close the poll and share the results. Okay, so looks like about 40% of you went with answer choice C, serum lipase concentration. And then almost a third of you went with Sudan 3 staining. About a fifth of you went with colonoscopy. And then, a handful of folks went with the answer choices A and D. So really kind of a two-horse race for this one, based on the crowd's response. So let's go ahead. I'm going to close the poll and reveal the answer. And the answer is answer choice E, Sudan 3 staining. So definitely probably the toughest question of the night, and obviously not the leading vote getter. So some stuff for us to kind of work through here. So I'm going to hand it over to Abraham and have him walk you through it.
All right. Well, good try, guys. I think this was a tough one, and there's a reason why it's the last question. Is there's a lot of I think this is a different question. Oh, there it is. Okay. So the answer here is E, Sudan 3 staining. I want you to see the full picture, understand what's going on here. Let's go through, read through the question again. And let's come up with a diagnosis before we tackle the options here. Again, we have this guy, he's 40 years old. He's got a history of alcohol use, right? So he gets recurrent acute pancreatitis. Someone who's alcohol, gets acute pancreatitis, and just keeps getting these recurrent bouts of acute pancreatitis. So what happens if I keep getting acute pancreatitis? Well, eventually, this will lead to a chronic pancreatitis situation where the pancreas fails. And the pancreas has two roles in the body. It has the endocrine role, which is, secreting insulin, glucagon, helping manage my blood sugars, and an exocrine role. The exocrine is, it has my lipase, has my tryptase, my, different secretory enzymes from the pancreas, which help me digest food. And particular lipase is very important, right? Without lipase, with the pancreas working, we can't absorb fats in our body. We just poop them out, right? And that's why her stool is oily and smelling worse than usual. That's fatty stools, steatorrhea. That's what they're describing there. So, and if we can't absorb fats, we're going to lose weight, right? Fats are major portion of our caloric intake. So they're having malabsorption of fat due to pancreatic insufficiency, secondary to previous alcohol use and recurrent pancreatitis. That's the story that they're building at the top there. Okay, so weight loss, secondary to steatorrhea, which comes from his pancreatic failure, which comes from his recurrent alcohol-related pancreatitis. Now, how do I further work this up, right? These options are all good. And I see why most of you guys pick C, because you guys see pancreatitis, you think lipase. Pancreatitis thinks lipase. Now, lipase will go up in acute pancreatitis, but it's not going to tell us anything about malabsorption. And a lot of times in a chronic pancreatitis, you can have a normal lipase level without understanding what's going on, right? This question is not asking about, 3 years ago when he had acute pancreatitis, well, what do you want to check? No, that obviously you check lipase. Lipase is going to tell you about acute pancreatitis. He's had already that in the past, multiple bouts in the past. What they're asking about now is, why is he losing weight? Well, it's not because he's in acute pancreatitis, it's because he's in chronic pancreatitis. So that malabsorption and that fat in the stool, it's not going to give us that answer. Okay, let's rule out the other ones. A, transglutaminase. A couple of you guys picked that. That's, again, going back to celiac disease. Celiac disease also presents with weight loss and steatorrhea, but the patient's history of recurrent pancreatitis points away from that. All right, you're talking about bread, things like that. That's when you want to go with A. Colonoscopy, again, you can look at it. If there's something structural, if there's something bleeding, some polyps, you can catch that. But it's not the best for malabsorption. You're not really going to figure out, the pancreas isn't secreting lipase or pancreas isn't having its function work. That's why you're not, right? This is asking about serum concentration of lipase, not asking about lipase secreted in the intestines. It's serum. And that only goes up in acute pancreatitis. Ova and parasites, again, not really the clinical picture you're going to see here. The patient's history with that recurrent pancreatitis really doesn't point towards that as cause of malabsorption. Now, what is Sudan 3 staining? Right? Sudan 3 staining, it's the sensitive screening to essentially qualitatively stain fat in stool. And it helps confirm that, hey, there is excess fat in the stool, and that confirms the steatorrhea that you expect the patient to have. Now, there's a way you can do it to quantify it by doing a 72-hour fecal collection. That's a little advanced, nothing for you guys to really be aware of, but just a high yield point is that Sudan 3 stain is going to help us qualitatively say, hey, is there fat in the stool or not, excess fat or not? So this confirms the steatorrhea, and then use the clinical picture to come up with a diagnosis of, this is pancreatic insufficiency. These people will also be deficient in fat-soluble vitamins, right? ADEK, you got to think about that as well. So think about everything that could be going on. Other people that can also have pancreatic insufficiency is my cystic fibrosis patients. So these are all high-yield kind of factoid things you need to know, but seeing the overall picture and building the clinical picture in your mind is going to be the answer in this situation. But great job, guys.